Welcome everyone to our afternoon session. Come on in and have a seat. We'll go ahead and get started. This is our session on understanding pain and pain management in arthritis. So please help me welcome Dr. Nortiz.
Hello. Can you hear me? Can you hear me in the back? Okay. All right. Thanks for having me. I was asked, how do you pronounce my name? It's Gary. Welcome to our fair city. I live and work here in Columbus at Nationwide Children's Hospital. I take care of both adults and kids. So I'll tell you a little bit about me and how I got interested in this, and kind of where I am and what kind of things I might be able to help you. So let me go through a few things. In medical talks, we often start with these disclosures where I'm here to tell you that, I don't know anything for the things I'm going to tell you. I haven't worked with drug companies around any of these medications. I am going to say that a lot of what I'm going to talk about is what's called off-label, which means that the Food and Drug Administration has not said this is a approved indication for this medicine or this device. You may find more and more, the more you read and look in things, not much of what we do in medicine is FDA approved, but we are supposed to tell you ahead of time that these things are not, fully FDA approved. Okay. Goals for the talk. All right. So first of all, I'm a big soccer fan. I played goalie back in the day. I've never made a kick save like this on a penalty shot, but a guy can dream. If I'd been a better soccer player, I might not be here today, so I guess it's okay. So I want to talk about pain. It's not everybody's favorite subject, although it seems to come up often. And I want to talk about different medicines we use and why we use them, and different modalities aside from medicine that we use to treat pain. One of the things I came in at about halfway through Dr. Hall's talk, and so I understand first of all that that's a very hard act to follow. So I appreciate your patience with me. That was just a great speaker. That was really great. One of the things that kind of struck me as I was listening to her talk was she said something along the lines of, you're 99% the same as the person sitting next to you. And so even if you have arthrogryposis, you are sitting next to somebody who doesn't, you're still 99% a person first, and secondly, a person with arthrogryposis. And so I'm not here to say that I'm an expert in treating pain with arthrogryposis, although I have done that. But I've treated pains in lots of people with lots of different conditions, and a lot of what I've done, I think, is applicable to people with particularly arthrogryposis. So I trained in something called MedPeds, which is a combined residency in both internal medicine and pediatrics. It's a good place to go if you kind of don't know what you want to do when you grow up, because first of all, you get to postpone for 4 years making that decision. And I just sort of happened to train in a place that had a big program in taking care of kids with disabilities. One of the things my mentor was pretty interested in was arthrogryposis. So even as a resident, I saw more than I think my fair share of people with arthrogryposis. And then as I stayed on to join the faculty there, it became clear that children with disabilities become adults with disabilities and kind of need somebody to help take care of them too. One of the things we can talk about a little bit is how ready or not ready the sort of adult system is to take care of people with a disability. Like, you think it's hard on the pediatric side. All of you who have a little gray hair or a beard or whatever, know what it's like to come to the adult side. You got to start out with, okay, well, what's this big long word that I have, this arthrogryposis, and so on. So I do want to probably spend a little time later on in the talk mentioning that. I'll just say that, in my opinion, it's okay if you go to a doctor for the first time and they've not heard of arthrogryposis and they don't know a whole lot about it. But if you come back the second time and they haven't learned anything about arthrogryposis, that to me is a red flag. Okay? So, but if you can find a doctor who's willing to learn something, I think you'll be in good shape. Okay, but we're going to spend our time talking about pain. Okay, so there is an International Association for the Study of Pain. These are primarily anesthesiologists and those kind of people, and they have to have a big highfalutin definition of what pain is, and this is what it is. An unpleasant sensory or emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So that could be, my tissues are right now being damaged by something, or it feels like they might get damaged, or it feels like they are getting damaged, even if they're not. And the other thing is that pain is always subjective. I can't look at a person and say, you're having pain, you're not having pain. You're having more pain than that person over there. All I can do is listen to you describe your experience with pain. And that's hard on doctors, right? We like numbers, we like tests, we like, especially if they cost a lot of money. We'd love to be able to, quantify these things, but we just can't in pain, which means we have to trust what patients are telling us. Okay. I also want to sort of focus on that pain is different from suffering. Okay, pain is one thing, and people have pain. People with arthrogryposis, people without arthrogryposis. Pain is part of living as a human being. What we're really hoping to decrease is not just pain, but suffering, which is sort of the total experience of being a person, and the physical pain, or the emotional pain, or the spiritual pain that somebody might be undergoing. That threatens what it means to be a person. Okay. And while we have some medicines that can help with physical pain, some medicines that can help with emotional, psychological pain, other interventions that help with other kinds of pain, suffering is a big circle of which it takes, really a team to take care of. Okay? And in general, as doctors, we ought to be more interested in suffering than in pain. Cicely Saunders, who was sort of credited with founding the modern palliative care movement, the modern hospice movement, talked about this thing called total pain, which involved all these things that I'm talking about, not just that physical component, but the emotional component of having pain, the psychological component of having pain, the spiritual component of having pain. And often, a person has pain in all of these dimensions. And if we only focus on the physical pain, we're not really going to get to the bottom of why things hurt so bad. Okay, we need to, really get to the core of all these things that are part of pain. And for people that have depression and people that have anxiety, that makes pain worse. And for people that have pain, that makes depression and anxiety worse. And so I don't think it's surprising that a lot of the things we do to treat pain really have to have this multimodal component and talk about mood and talk about anxiety. And one of the worst things about having pain is if you're going to do something and you know it's going to hurt. Going up to do that thing, really adds to the pain. Okay, so I put the talk together and I said, well, what's out there on pain and arthrogryposis? And there's quite a number of things. Some of it was written by Dr. Hall. Some of it was written by other people that I'm sure are here. This is hot off the press. It's not even printed in a journal yet. It's only on the website. And there's this thing called the OSTRI Disability Index, which is an old school. It was first published in 1980. But these people did a very interesting and very important study right now, which is they took a group of people with arthrogryposis, perhaps some of you, and said, does this mean anything to a person with arthrogryposis? Can this mean, can we use this to measure pain and other symptoms of disability in arthrogryposis? And it turns out, yes, you can. And of course you can, because people with arthrogryposis are in most ways not different from other people. But in order to do these kind of studies, you got to kind of get a group of people together and do this. Okay. This just came out last year, I think, 2017, and sort of compared a group of people with arthrogryposis, volunteers, to sort of a group of what is considered average, I don't want to say normal, but average or typical people in the US in terms of things like how physically limited are they? How emotionally limited are they? What's their mental health like? How much pain do they have? And there are, okay, that's not the pointer apparently. In a lot of these domains, people with arthrogryposis report more pain than the average person in the United States, and less adept physical function and more physical limitations. But it's not, if you look at that pain, and they didn't put the number on it, but it's like 60% experience bodily pain on a regular basis, whereas it's about 50%, I think, for the average US population. So it's out there and it's important in arthrogryposis. The interesting thing that we sometimes refer to this as the disability paradox, is that people with disabilities in general often rate their quality of life not that far off from the average person. Now, the average person who doesn't have a disability looks at somebody with a disability and says, oh, their life must be pretty terrible. It must be so hard. They must have all this pain. They must be depressed. They must, because they can't do these things that I, an able-bodied person, can do. And when you do these studies, it actually is not the case. People with arthrogryposis, I'm not saying people with arthrogryposis, people with disability generally rate things like that pretty similarly to the average person. And why is that? Well, people have learned to cope. People have grown up with a certain disability and have figured out ways around, ways to get over these things. Okay. Let's talk about a few specifics of pain, okay? This is a slide I use when I talk to residents about why people with disabilities have pain. I put it highlights things that I think might be more often in people with arthrogryposis, and you can sort of correct me if I'm wrong about that, but I put these things up there. And so, first of all, we all have pain. I woke up this morning with a headache. Not a bad headache, but a headache. I also had a big barbecue last night at the 4th of July, and I woke up with an awfully bad stomach ache, which I'm actually going to talk about a little bit later on. But pain, again, is part of living. But these are things that I bet are more common in people with arthrogryposis. I don't know that I have data to back this up. But I bet kidney stones are common. Anybody here had a kidney stone? Okay. Fractures are common. All right. And all the orthopedic problems that you folk have, I think, are really add to these kind of things. My friend Dr. Williams over there is going to talk about bowels and gas and everybody's favorite subject after pain, after me. And so we'll sort of really get into that next. But I think that that's something that really a lot of people struggle with. This abnormal body mechanics, overuse syndromes, I think that's probably the core of a lot of musculoskeletal problems for people with arthrogryposis. And going back to what Dr. Hall said, the human body is an amazing and very imperfect mechanism. And even when it works exactly as it's designed to by whoever designed it, scientists like to say genes, any little thing that sets it off kilter makes it not work very well. And so any time that one leg is several millimeters shorter than another leg, and this is just an average person who doesn't even realize that they have one leg a little bit shorter or longer than the other leg, that throws off the hip, that throws off the knee, that throws off the back. Adding a really serious difference like we see in arthrogryposis, and you get into these kind of problems. Nerve impingement, as those nerves come out of the spinal cord and go all the way out to the muscles and the skin. I think in arthrogryposis they probably take some weird turns, and they get stretched in odd ways, and that is a source of pain, is my expectation. And then there's something called wandering spleen. Anybody ever heard of wandering spleen? Anybody here have wandering spleen? It's just interesting because as I was sort of Googling around trying to find some evidence for this, there was one case report of a person with a wandering spleen, and they did the surgery for wandering spleen. Oh, and by the way, that person had arthrogryposis. And they said, I have one patient with wandering spleen, and she has arthrogryposis. Isn't that weird? That might just be a coincidence, but I'm gonna talk to some people and find out about this. So what's wandering spleen? Basically, the spleen is this organ. It sits up here. It filters the blood. There's a ligament that kind of holds it in place under the rib cage, and in some people that ligament is loose, and it kind of drops down into the abdomen and can sort of wander around. And if you do a CAT scan, one day it's in this place, and one day it's in that place, and it hurts because it can get twisted up on itself. Okay? It causes pretty bad abdominal pain. It's really rare. I don't want to spend any more time on that, unless the whole room has wandering spleen, and then I really want to talk to you. Okay. Principles of treating pain. Okay. People want their pain treated. People are afraid of pain medicine. Okay. That's okay. What is ambivalence? Ambivalence is feeling two ways about something at the same time. Okay. But there are lots of different pain meds. They all kind of have their own different profile. They all have potential side effects and some different side effects. And you may read the label and say, ooh, that's not for me. Too many side effects. Realize that every single medicine anybody might take has a whole book of side effects that comes with it. And it's kind of really up to you in collaboration with your doctor or your kid's doctor to talk about, well, how likely are these complications? How bad are these complications versus how bad is this pain that I'm feeling? And living in pain is not good for you. So while I urge people to have a healthy respect for medications, we use them. That's what we do in medicine. But there's a lot more to pain treatment than pain medicines. And I'm going to spend sort of a bunch of time on pain medicines. Then I'm going to get to talk about some what we call non-pharmacologic or alternative kinds of ways of treating pain, all of which I think can be important and lots of our patients use. Stretching, bracing, getting good seating for a wheelchair, if you use a wheelchair. Sleeping enough. Not sleeping makes a person hurt. So if your problem is you're not sleeping, we got to work on that. Exercise is important. Massage is great. TENS is something called Transcutaneous Electrical Nerve Stimulator. I'll talk a little bit about that. Then there's this whole panoply of things we call complementary alternative medicines. And then there's orthopedic medicines. But remember this slide, we're going to see it again. Okay. Docs, we like to break things down. We want to say, okay, well, there's pain, but there's different types of pain. You want to think about what kind of pain a person's having when you choose a pain modality to treat them. And these are sort of the three main ones. First, somatic. That's the most common one. That's where your body hurts. Visceral. These are things where your organs hurt, and we'll talk a little bit more specifically about that. And then there's neuropathic, which is when your nerves hurt, or when your nerves are driving the pain. And I want to mention one more thing. I try my best not to speak doctor to people, even when I'm talking to other doctors, but if I should lapse into phrases that you guys don't know, somebody put their hand up and I'll get back to speaking English. I apologize for that. Okay, somatic pain. This is what you have when you stub your toe, when you break your leg, when you burn yourself, when the doctor gives you a shot. That's somatic pain. It's pretty direct. You can usually say, it hurts right here. You can say, this is when it started, this is when it stopped. And it's really that feeling of the tissue being injured in some way. And the words that people use to describe the pain are important. And this is how, when the pain is hard to figure out, this is how we tease it out, is listening to people describe the pain. What are the words that they use? So things that people use when they have somatic pain is stabbing, sharp, throbbing, pressure. Okay. Everybody has somatic pain. I think everybody's experienced this one time or another. Okay, well, what do we do about it? Well, this is our sort of standard pain medicines. Okay? Acetaminophen, in this country we call it Tylenol, it's called other things in other countries. That's the first thing everybody reaches for, and with good reason. Works for a lot of stuff, pretty safe. Second, these anti-inflammatories, some of them are steroids like prednisones. A lot of times over the counter we talk about things like ibuprofen or Motrin or Aleve or Naproxen. Again, pretty effective for certain things. Some side effects, which we'll talk about, generally safe when used as directed. And then we have opioids, which is like morphine and its cousins. Again, for the right person at the right time, we use it. Okay? Has to be used carefully, and we'll talk about that. Those are things you can, sort of take by mouth or take in an IV. There are these topical things, creams or patches that you can rub on, like lidocaine patch. Really pretty effective for certain things. Anti-inflammatory creams. Like if you have a pain right here, and especially for some reason, if you can't take a non-steroidal medicine, putting a cream right on that place that hurts can be helpful. We can inject steroids into a joint that hurts. Sometimes we'll do that to find out, is this the joint that hurts or not? Because we'll mix it with a steroid and a lidocaine, and if it feels better, pretty much that day we'll be like, oh, I bet that really was the problem. Sometimes we don't know if that was the problem, and we inject it, it doesn't do anything. We're like, maybe it wasn't that joint. Then there's other invasive modalities that pain doctors might do, like injecting steroids into different parts of the spinal column. Or there's a thing called radiofrequency ablation, which stuns the nerves at various points in the spine. And in addition, there's all this other stuff that we think is great. Ice, heat, massage, guided imagery, and we'll talk about all of this. Okay, that's somatic pain. That's your sort of standard pain. Okay. I want to talk for a minute about visceral pain, and this is what Dr. Williams and the GI docs and other people that deal with the internal organs spend a lot of time with. And this is what I had this morning after my dietary indiscretion with barbecue and stuff. Okay? When your stomach hurts, it kind of hurts there, where your stomach is. I didn't mean to do that. Okay. But visceral pain is tough. It doesn't always hurt right where the organ is. Sometimes it's transmitted to other places. And a place that I, for some reason, tend to get a lot of stomach pain is up here in my neck. Okay, anybody else have that experience? That you get real, let's not get too personal, you get real gassy and you get pain in your neck up here? It's because the stomach has nerves that go up this way. And they're carried on those nerves. Your stomach's down here, but it hurts up here. And all these sort of internal organs have some of these things. And when the internal organs are inflamed or unhappy for whatever reason, the way people talk about that is cramps, comes and goes, stabbing, achy. And sometimes it's hard to say. They're like, it's kind of like over here. It's kind of like down here in the hip or in the pelvic kind of region. Okay, and all your internal organs have these sort of hollow tubes. Stomach, intestines, ureters, which bring the urine from the kidney down to the bladder, the fallopian tubes of the ovary, things like that. When they're unhappy, they have something stuck in them or they're kinked together. It's a weird pain. It comes, it goes. It can really hurt a lot. But it's often different from that stabbing pain or pressure pain that you feel with, when you have, gotten cut with a knife or something. Okay, and so telling your doctor it's this weird kind of pain and this is where it hurts, the doctor ought to be able to say, oh, well, sometimes when you have pain back there, we can trace it back to the kidney or something. So what do we do about visceral pain? Kidney stones is a visceral pain. Well, so we use a lot of the same things we use, non-steroidals, morphine and its cousins. But another thing we can do is try to fix what the problem is. Okay? If you've got a kidney stone, we can try to treat your kidney stone, get your kidney stone out of it, however it is. If you're constipated, you're going to spend the next hour talking about constipation, reflux. Okay, these are all things we experience from time to time. And then there are these, again, non-pharmacologic things that you can do to relax and help your brain cope with the pain. The third kind of pain I don't want to say it's the most important one, but it's the most vexing one. And when people have chronic pain, even if it started as that regular body pain or organ pain, it ends up here at neuropathic pain, and we have to use these neuropathic pain treatments that I'm going to talk about. So the first kind of neuropathic pain is where you have a nerve that's irritated because it's being pinched, or you have diabetes and it's metabolically abnormal. And the way these are described is tingling, pins and needles, burning, or electric. It's like there's a shock running through my body. A lot of people have this, it feels like I'm wearing gloves, like, I'm touching things, but I can't really feel it. And that's some people don't find that very uncomfortable, other people really do. People also experience neuropathic pain, I think, in fairly different ways. And it can be accompanied by weakness, especially if there are nerves that are getting pinched and so on. Now, when you have a pain that's gone on for a long, long time, like, let's say, a back pain that's musculoskeletal in nature because you have something, a joint that's rubbing the wrong way, it can become a neuropathic pain because how do you feel pain? Your nerves transmit it up to your brain. And when a nerve is constantly transmitting up to the brain, it keeps doing it even after that pain is gone. Or even if that pain gets less, the nerve gets sort of stuck in this cycle. And so the neuropathic pain meds that we use often help with that. The usual medicines are not great for this. Okay? And that's why one of the reasons we've really tried to get away from using opioids for chronic pain. Because there are other things that we think tend to work better, although we have to use them sometimes. The medicines we tend to use are anticonvulsants or seizure medicines, certain kinds of antidepressants, and local anesthetics. We'll talk about that. But in terms of opioids, methadone, which everybody sort of thinks of, oh, that's the medicine you use to get off of heroin, which it is actually a really good pain medicine. And it works both on sort of your regular pain receptors as well as your neuropathic pain receptors. But it's a bit of a complicated medicine to use, so not everybody uses it. You may have to, if that's what you need, you may end up in a sort of pain clinic situation. But it can be pretty effective. Okay, stop for a second. Let's talk about some myths. Myths of pain that people have probably heard, and I hopefully can discourage you from believing them. One is we can't give you strong pain medicines now because when you really need them, you won't be able to take them. Okay, anybody heard that one before? How about especially in the hospital after, some surgeons cut you open and whatever, and they're like, we don't want to give you too much strong pain medicine, but doc, you're just inside me and doing all these things. That's an okay time to use pretty strong pain medicines. So first of all, there's no such thing as a maximum dose of the opioids. Okay? Those medicines, as long as you increase them slowly, carefully, they can be used. And we can go up to what would be considered pretty big doses because people get used to the doses over time. I have many patients that take kind of big doses of these pain medicines, but if I took even a tenth of their dose, I'd sleep for days because I don't chronically take pain medicines. But if you work up to that, not only is it needed, it's also safe. But if you try to tough it out, you can run into trouble. Okay? And you can get what we call behind in your pain medicine. And we don't want you to do this. I'm talking again specifically about kind of acute pain. You just had an injury. You just had a broken bone. You just had a surgery. Don't try to be a hero. Okay? Number two, we got to talk about addiction. Okay? Addiction is a very serious problem. A lot of addiction, and we'll talk. A lot of addiction in this country and in this state has been driven by docs using pain medicines kind of cavalierly. I'll confess that I used to be one of those docs. I used to, really treat a lot of people with opioid pain medicine that, in retrospect, I really should have been working on some other way of treating them. But when you use pain medicines appropriately, addiction doesn't seem to be that much of a problem. And how do we decide what's appropriate? Okay, so number one, we got to talk about some terms. Okay, What's dependence? If you take a pain medicine for long enough, I can guarantee you'll become dependent on it. And what does that mean? That means that if you take the medicine away, you'll have what they call withdrawal symptoms. If you're used to taking a medicine like morphine, you take the medicine away, you're going to have, you abruptly take the medicine away, you're going to have these sort of symptoms, which mean your body has been used to taking it. You'll have pain, you'll have sweating, you'll have diarrhea. That doesn't mean you're addicted. That means your body has physiologically become accustomed to taking the medicine. And if you want to get off the medicine, you can, but it has to be done slowly and importantly. Also, people are tolerant. You get tolerant to their pain medicine, and that's that going up kind of in dose over time. What addiction is when you have those things, but you're also doing things that are inappropriate, illegal, socially unacceptable to get pain medicines, because you're psychologically, in addition to physically addicted, you're psychologically addicted to them too. And that is a whole separate disease that we've unfortunately had to learn a lot more about. Okay. When you use pain medicines inappropriately, as I believe I have in the past, and I think probably a lot of doctors have too, you can lead to addiction. So we should know a few things about them. One, painkillers should be used for as short a time as possible. It's okay to use them. Use them for as short a time as possible. Use them in doses that are appropriate. Know your risk factors for addiction. What are risk factors for addiction? Big one is family history of addiction. If there's other people with addiction problems in your family, we don't know why, but you're more likely to have that kind of a problem. And it's important to talk to your doctor going into it. You got to follow the prescription. If the prescription says take, no more than 4 doses a day, please don't take more than 4 doses a day. Don't use non-prescribed painkillers. Okay, somebody's got some Percocet left over from a procedure they had before. That's not yours. Don't take it. Okay. You consider alternative pain treatments, some of which we're going to talk about. And I'll tell you, one of the ways that I think I really got into trouble with some of my patients a disservice in the past was when I didn't pay attention to their total pain. I focused on their physical pain, and I didn't also try to help them treat their emotional pain, their psychological pain, their problems with depression, anxiety, their spiritual pain. Okay? I'm not an expert in treating spiritual pain. I work with chaplains who are expert in treating spiritual pain. But if a big part of your pain is, why did this happen to me? What did I ever do to God that I have this pain? That's spiritual pain, and that needs to be addressed too. And there's no amount of morphine I can give you that will make that better. Okay? So we have this opioid crisis in this country. This is already 6 years old. I want to point out that in this big purple swath of the nation where we're standing right now, in 2012, there was more than one opioid prescription per person written. Okay? That's a lot. Okay? This, I don't have this data. This has actually started to turn around a little bit, but we still have a very big problem. Okay, but I pointed out to say, I don't want you to be in pain, and if I see a person who's in pain and an opioid is the appropriate medicine for them, I want them to have it, and I want to work with them to use it as short a time as possible and explore what other options might be.
Does that mean through their whole lifetime?
In a year.
In 1 year's time?
So in 1 year, like the people of Ohio, I think the number was 100 people in Ohio had I forget, if there's 3 million people in Ohio, there were 4.5 million prescriptions. Something along those lines. We can't give morphine because it affects breathing. People have heard that, right? Okay. So it's true that if you give a healthy person who doesn't have pain a pretty big dose of morphine, they'll fall asleep and their breathing will become pretty shallow, and if you give them enough, they'll stop breathing. But people in pain have a heightened response to that because of their pain. And so we actually don't find that to be very much of a problem, again, using appropriate doses for appropriate lengths of time. Okay. The people I work with are talking to a family about their pain, there's a whole bunch of things that we got to take into account, like how old is this person? Are they a child or an adult? Can they swallow pills? Do they need liquid? I'm already practically out of time. I apologize. What are the goals for the pain? Okay. Is it a reasonable goal to say, we're going to take your pain away completely? You're going to have zero pain from here on out. I'd love to do that. It's not always a reasonable goal. Okay. But so a lot of times the goal is, can we get your pain down to low enough where we can get you to function, where you're able to get out of bed and do the things you need to do, or you're able to get out of the house and get to work, or get to school, or whatever the things are. Okay. Everybody's got acute pain. Sorry. Everybody should take this pain medicine, but these are things we use. So Tylenol, because it's so easy to get, it's so cheap, and you can just buy it in the drugstore, people kind of don't think of it as a great pain medicine sometimes. But it really can be. Okay? Now, maybe you've got to take you may have to take sort of standard dose several times a day, but it's a good pain medicine. Okay? In long term, and when you take too much of it, it can cause liver disease, and that's bad. If you already have liver disease, you should be careful about it. The other problem is that lots of things have Tylenol in it, and you don't know that. Like Percocet is oxycodone and Tylenol, so you can't take Percocet and Tylenol. And lots of cold medicines have Tylenol and all kinds of other things mixed into it. So just be aware of all the things that you're taking. Ibuprofen, this is cut off. Non-steroidal anti-inflammatory drugs, things like ibuprofen, naproxen, naproxen. These are good pain medicines too. They're anti-inflammatory. They reduce inflammation. Some of these are approved by FDA for certain ages and not others. Some are approved for certain indications and not others. Again, you got to be a little bit careful and talk to your doctor with it. Things important to know, one is it can really upset your stomach or gastritis. It can cause bleeding ulcers, things like that. There are things we can do about that if this is the medicine you need to take. Just taking with food sometimes is enough. And over long periods of time, and if you're an older person, what do I mean by older? Older than me, it can cause kidney disease. These are not even all the opioids, but these are some of the opioids. Morphine, Dilaudid, Demerol, methadone, fentanyl, oxycodone, hydrocodone. They're all cousins. They're sort of, in some ways, interchangeable. But the dosing is different. So they talk about these things called morphine equivalents. And so 30 milligrams of morphine orally is equivalent to 10 milligrams of morphine IV, is equivalent to 20 milligrams of oxycodone orally. And so to some extent, they're a little bit different. You know how some people really like Coke? Some people really like Pepsi? But for most people, it kind of doesn't matter. But it's kind of like that. For most people, it doesn't matter which one you use. But now and then you find people that, they're really, like I'm a Diet Coke guy. It's Diet Pepsi if you twist my arm, okay? But they're a little bit cousins. They hit receptors a little bit different. You have to know what the doses are. They have really quite a bit of side effects, right? Nausea, sedation or falling asleep, itching, constipation. And then there are these risks of dependence, tolerance, addiction, diversion. Where do a lot of the pain medicines that people are abusing comes from? The medicine cabinets of people that need pain medicine. Okay? So where is your pain medicine? Who has access to it? Just because you're using it appropriately, how do you make sure that it's staying in your control? Okay, getting on to the neuropathic pain or the chronic pain treatments which we use. Anticonvulsants are kind of a mainstay. Gabapentin is the one that we use the most in Neurontin. When I bring this up to people in the clinic, they're like, yeah, I've been on Neurontin. Okay, well, let's talk about what doses you used, how it worked for you, that kind of thing. It's really our mainstay. It is FDA approved for the treatment of seizures and the treatment of shingles. And that's it. It is not approved for chronic pain medicine, even though that's what it's used for by far most in this country. We don't exactly know how it works. It seems to dampen the nerves talking to each other and transmitting pain. It's got side effects, dizziness, nausea, vomiting, fatigue. I don't find a lot of side effects with it. Some people have them. Some people really don't feel great emotionally on them and they'll stop it. I personally never had anybody come to me and say, I'm having suicidal thoughts, or have their family tell me about suicidal thoughts. It is certainly reported if you or a loved one are taking gabapentin, particularly as you get started. It's one of those things to kind of just be aware of. We've got to be careful on people with kidney problems. It has a cousin called Lyrica. Same thing, not FDA approved for this purpose, but commonly used for this purpose. Okay? There's a few other seizure medicines we use for that, for this indication, and we think it works in kind of the same way, just as the seizure medicines work from dampening the signals between this nerve cell and that nerve cell talking to each other. We think it affects pain. There's a class of medicines called Tricyclic Antidepressants. We use these a lot. Elavil is probably the biggest one. Not only are they good for pain, they're good for mood because that's what they're FDA approved for. They're often good for sleep. They're not FDA approved for that either. We get a few more side effects with this class of medicines. Blurry vision, dry mouth, constipation. In people who have certain heart rhythm abnormalities, you've got to be careful. There's something called long QT syndrome, which essentially means how the heart resets itself beat to beat. So if you ever have any problems with that, or if there's family problems with that, it's not that you can't use this medicine, it's that you got to get an EKG to look at it. There's other antidepressants. There's one called Effexor that I like to use. Again, FDA approved only for mood problems. I think it's really pretty effective for pain. A big problem that people don't like is it can make you pretty sweaty. Okay? Might be worth it if it really helps your pain, but people do complain about the sweat. Okay, non-pharmacologic stuff, and I really should have spent much more time on this than the pharmacologic stuff. But there's all these different things that are not FDA approved because the FDA doesn't have to approve things like massage or essential oils. Those are just things you can try. I want to point people to this website, National Center for Complementary and Integrative Health. My slides will be available and you'll be able to zoom in and be able to see the website. But this is where I go when I want to know about a specific quote unquote complementary pain medicine kind of treatment, and I encourage people to go there too. There's lots of stuff on the internet. This is the truth on the internet. Okay, this is where you can find actual medical evidence about using some of those things. A lot of it's sort of cancer focused, but there's a lot of it that's pain focused too. Okay, but to be cautious about CAM, complementary alternative medicine. So number one, we're doing more research on it that says, hey, it kind of works. And a lot of times it has less side effects than all the stuff that we doctors have been using. But the overall weight of the evidence is still kind of small. Okay? It's still less rigorously studied than some other things. I say theory because a lot of what we think of as traditional medicine is not as well studied as it should be, but here we are. Make sure to tell your doctor about it because just because it's an herbal kind of preparation doesn't mean that your doctor doesn't need to know about it because it can interact with other medications. And if you read on the internet about something that seems too good to be true, it probably is. And that's whether you're looking for a pain medicine or trying to win the lottery or wiring money to that prince in Nigeria who always needs a place to park money for his bank account. It's too good to be true, it probably is. My personal opinion, it's great complementary stuff, and that means in addition to the other things that you're doing. Not always as an alternative. So about herbal remedies, like I mentioned, just because it's natural doesn't mean it's safe. Okay? There's a plant called foxglove. We make a very powerful heart medicine out of it called digitalis. take too much of that, you'll die. Okay? So, it's good for what it's good for, and not what it's not. But these herbal supplements, which are commonly taken, sometimes for pain, do have side effects, do have medicine interactions. A big one that's people take pretty frequently is called St. John's wort. Seems to be pretty good for depression. Why is that? It actually has some of the same medicine in it that antidepressants do. And so, it's okay if you want to take that for your depression, but you might also take an antidepressant and have too much of that medicine, serotonin, and run into trouble. Okay, relaxation techniques. We all need to relax, right? Number one, put your phone down. Take a picture, go ahead. But you need to relax. If you need to relax, very first thing is turn the lights off and put your phone down and find something to listen to take your mind off your pain. Okay. Now that's just me saying, hey, chill out. There's an actual body of evidence around certain things like self-hypnosis. How do you shut your mind off? Things like guided imagery and biofeedback. Okay? These things really work. Okay? You got to find somebody who can teach you to do it the right way. They really don't have side effects. So I once fell asleep in a guided imagery session. And that was a little embarrassing, but sure. Okay? Massage and aromatherapy. Okay? People with sore muscles like massage. Generally. I personally don't. I get sort of skeeved out by it or something. I don't know. But most people, I think, really like massage who have sore muscles, and I think that for people who have Arthrogryposis, that ought to really be something that goes. There are these things called aromatherapy or essential oils. A lot of my patients love this. You can tell when some of them are in the office. It just smells better that day in the clinic than other days. I always what makes something an essential oil? It means it was sort of extracted from the plant itself, not using chemicals in the extraction. But there's some science. We think about how it works. The nose goes up to the brain controls the mood and that kind of thing. There are some side effects. It can irritate the skin. You can be allergic to it, things like that. It might not smell that great if there's a garlic essential oil, but I'll leave that to you whether that's a good smell or not, but you've got to be careful. There are these things called TENS units, which are essentially sort of giving, I think of it as giving a shock that overwhelms your pain center. And so I did this as a kid, and I never quite understood it, but you stub your toe and you step on your foot. Okay, people have done that? It's not just me, right? Okay? It spreads the pain out. Okay, that's the way I think about it. Okay? It might just be me. Okay. Well, next time you stub your toe, I don't know. But anyway, these things kind of overwhelm the pain centers. It's like putting the nerve on overdrive. These shocks don't necessarily, people will feel them, they don't necessarily feel them as very painful. If you feel it as pain, it's probably too high, or it might not be the right mechanism for you. The pads can irritate the skin, you can get muscle twitching and tingling. There are these energy therapies like acupuncture. What energy therapy means is there's this theory, mostly in Eastern medicine, that there's energy that runs through your body. And pain is this energy being diverted in some way. And things like this try to redirect your energy. I have not been a big believer. I have come to believe a little bit in some of these things. Acupuncture, this is how small the needles are over on the side. Much smaller than anything we might poke you with in the office. My thought on this is, to some extent, a billion Chinese can't be wrong. Okay, people will tell you it works. It's worth these things worth a try. Reiki is another thing. I'm actually involved in a study of Reiki in pain in people with cerebral palsy who have a lot of pain and discomfort for other kinds of things. I can't tell you that our study shows that Reiki works and reduces pain and that kind of stuff, but I can tell you, so far in our study, it's safe. People liked getting it, okay? And the person doesn't even touch you. They kind of, massage your energy without touching you. So again, we think it should be safe. Now, I'm not saying do these things and don't see a doctor and get your pain treated. It's the kind of thing that, in addition, you would try. Okay, so in summary, I really think there's lots of reasons a person with arthrogryposis might have pain. You all probably know that better than I do. There are lots of different solutions, but we got to get to the source of why does it hurt? Is this muscle cold? Is this nerve firing inappropriately? Is this bowel distended with constipation? We can fix those things and we can target our therapies there. And a multimodal approach is best. So if you go to a pain clinic, there's going to be a doctor who specializes in pain, but a good pain clinic's also going to have a psychologist that specializes in pain, a alternative medicine treatment person of some kind, acupuncture, massage therapy, Reiki therapist, or access to these other people, as well as a group to talk about the experience of pain, because that really does seem to be very important. So beware of pain doctors that only do, pain centers that only have a doctor. Okay? A doctor's not going to be enough for you, unless what your problem is, this nerve hurts and that nerve needs to be turned off with a nerve stimulator or something like that. A multimodal approach is best. Okay, I appreciate your attention, and I have a few minutes for questions. Thank you. I ran late, I apologize. I'll stay for a little bit if we're out of time. Go ahead.
Do you have much experience with prescribing medicinal marijuana?
Medicinal marijuana, I knew that would be, if not the first question, at least the question I would get. I personally do not. We are not yet prescribing, or we will, medical marijuana in Ohio right this minute is a little bit in limbo. It's been approved by the voters. The dispensaries are not yet set up. A doctor may recommend medical marijuana once their dispensary is set up. I have lots of people who have used medical marijuana and say it really helps them, and I think that's great. One of my problems is when I prescribe a medicine to you, I want to know that you can go to the drugstore, and if I say you're getting 5 milligrams of oxycodone, that you're getting 5 milligrams of oxycodone. So at the dispensary, it's not clear to me what you're getting. You may be getting exactly what you think you're getting, you may not be. How many milligrams of cannabidiol are in it, how many milligrams of THC are in it. So, I think medical marijuana is one of those things that we just don't know where it is in our armamentarium yet. And it also just worries me about how it's like sort of medicinal, but sort of not, because the regulations are kind of so strange around it. Other states have more experience with this, where like a doctor could say, you need this strain and you should get it this many times a day, and you should take it with the oral form as opposed to the smoking form. There are people that know that stuff, or starting to know that stuff. I'm not one of those people yet. You had
You mentioned guided imagery.
Yeah.
How would you have to repeat to find a good, reputable person who can help use guided imagery for me?
That guided imagery, it's about a relationship between a person and somebody that can teach you how to do it, because you don't go back to them weekly for guided imagery. But it's the kind of thing I think you can find in most cities, people that can teach guided imagery, and it's about taking you out of this moment. Close your eyes, take you out of this moment. Think of a place where you're happy. Think of a place where you're comfortable. And a method to sort of find that place and leave the present and leave the pain here. Think about what it's like there, where the pain is not so bad. I'm pretty sure we do. I'm pretty sure we do. Google Nationwide and look there. I bet our pain people. You back there, and then you sir. Okay. Not me, and so it's sort of, the question was about hemp oil, which has the cannabidiol component, which seems to be the kind that works on nerves. Just last week, a seizure medicine was approved, which is made entirely of cannabidiol. So it's really the first FDA-approved marijuana product. It's not yet available for purchase, but it should be pretty soon. And it's sort of in that same thing, but it's the kind of thing that the company is going to say that, and I don't know how they're going to dose it, but if they say this pill has 20 milligrams of cannabidiol, it's got 20 milligrams of cannabidiol. But you know, same thing I've heard from patients that how helpful hemp oil and other forms of it. Second question. Okay, go ahead.
So, if I think of somatic pain and like breaking an arm,
Yeah.
the purpose of it is to keep me from injuring it more.
Say it one time.
If I break my arm and
Yeah.
I have pain, the purpose of it is to keep me from moving it more and breaking it.
Right.
So, if you think about like chronic pain and arthrogryposis, to what extent, if you're actually taking medication, are you maybe hurting the ability of protecting the joint for the long term, right? Because certainly you can now solve the pain, but in the long term, are you losing the protection effect?
Right. So
That's very much in the somatic.
yeah, this is a good question. So so I'll say it. So when you break your arm, it hurts a lot, and you stop moving your arm, and that and you go to the doctor, they put a cast on, and your bone heals. Right? Pain is useful in that respect. These other things, these sort of long-term neuropathic pains are dysfunctional. Okay, that's the nerves, not the hate. Okay, they've gone from doing what they're supposed to do, protecting you from breaking, hurting your tissues further, but to keep going. So
But I'm not about osteoarthritis or something
Yeah.
like that, but there's still something physically wrong.
yeah, but this is where you really have to sort of like individually with your doctor be talking about, so if you play football and you break your leg, they give you enough pain medicine that you can go back out on the field and play football and hurt yourself more. That's no good. But in general, if you have osteoarthritis or some joint rubbing together, one of the things you should do to make you feel better is get active, move it. Okay? You want to do it enough that you're making things better, not worse. And that's where, we don't take the pain away completely, but we make you function. You hopefully will still have, that point at which you're saying, oh wait, you've overdone it. That's too much. Okay, I'll stick around. Oh, sorry, go ahead. As a rule, I'd say no. I have a sense. My patients with AMC are kind of tougher maybe than my other patients. A little more stoic perhaps, but but they have pain and whenever it's different. I don't get a sense that they're like more sensitive to pain than others. But that's my guess. Okay, thanks everybody. I'll stand over here and Dr. Williams is going to talk about constipation.